Okay. Okay. So, cuba you all check. Semua dah ada ke? What's the total number of 4-year students?
84.
84. So all 84s are here. Okay, shall we start now?
Yeah.
All right. I think this is my first lecture, right, for you? For year 4, I think. Okay. Oh, semangat tak nak belajar cytology? You all excited to learn cytology?
Semangat.
Okay. Tak dengar suara, ingat tak semangat, kan? So by now you know already what is cytology, right? Okay, one student. What is cytology? Volunteer. Students? Hello, students?
The study of cell, doktor?
Ya, Ikmal ke?
Betul.
Okay, betul Ikmal. Right, study of cell, but in cytology, you will learn, okay, different to histology or pathology. I think you in cysto you learn normal tissue. Okay, in pathology you learn disease tissue. But in cytology you will learn both. But mainly on the cells. Okay, normal cells and disease cells, the pathological conditions of the cells. But we will cover mostly on cancer cases, right, in cytology, in the non-gynae cytology. Alright, so I will cover the pleural, pericardial and peritoneal cytology. Okay, I mean the fluid from pleural, pericardial and peritoneal cavity. Alright, I'm sure you... Dia tak full. Oh, nampak ke slide saya ayat ni? Ke terpotong ni?
Nampak doktor.
Nampak kan? Okay. Alright, so I'm sure you know already what are effusions. Okay. So effusions can be clinically classified as transudate or exudate. You learn already about transudate, exudate, right, in your year 2 and year 3. So, but in cytology, even though you know already what are transudates, what are exudates, but in cytology, we want to focus on in the pericardial, pleural, and peritoneal cytology. We want to focus on the exudate. Okay, not the transudate. Okay, so exudate has high LDH and total protein. So the effusion fluid or serum protein ratio is more than 0.5 and more than 0.6 for the ratio of fluid to serum LDH. So that's the difference between transudate and exudates. Okay, so in this topic, we will learn on the three fluids from the pleural cavity, pericardial cavity, and peritoneal cavity. So the effusions from these three cavities can come or can occur from previous on several conditions. Okay, first for pleural fluid, okay, the effusions in pleural fluid, a pleural cavity, okay, it can be caused by several sources of benign and malignant conditions. Okay, for benign, it can be due to pulmonary infection or infarction, or from abdominal diseases. And from malignant condition, of course, mostly from the cancer. But what cancer? Lung cancer, breast cancer, lymphoma, or GIT. And for pericardial fluid or pericardial cavity, right, the effusions sources comes from benign conditions such as infection, radiation, or hypothyroidism, or in malignant conditions, again in cancer, lung or breast, or lymphoma and sarcoma. While for peritoneal fluid, okay, the sources of benign conditions such as the portal venous hypertension or hypoproteinemia and salt retention. While in malignant conditions, in the examples of the cancer are ovary, breast, GIT, and lymphoma. So how are you going to collect the fluid from the three cavities, okay, that I just mentioned? So the pleural, pericardial, and peritoneal cavities are lined by a single layer of mesothelial cell. Okay, you know already this in the histology, year 1. Okay, the name of the lining, serosal layer, right? And it can be collected, the specimen in these cavities, through inserting a needle. Okay, if it is in the pleural space or pleural cavity, okay, the method is called thoracentesis. And for pericardial, pericardiocentesis. And for peritoneal cavity, the terminology is paracentesis, the method. So the fluid is collected, okay, from the cavity into a clean container and then directly sent unfixed to the laboratory. And the fluid from the three cavities can be collected in heparinized bottles to prevent clotting. And fluid also can be refrigerated at 4 degrees. If you can't do the slide preparation directly, you can refrigerate the fluid in 4 degrees. But if you can do directly, you don't have to refrigerate it. And then while after the sample has been collected, first you need to do gross evaluation. Okay, check the color, check the viscosity. And then you have to aliquot the fluid. Okay, because the same fluid will be need to perform for biochemistry analysis, cytology analysis, and microbiology analysis. So the fluid will be divided for these 3 laboratories. But we will cover the cytology part today. Alright, so how's the cytology slide preparation? Okay, after you collect the fluid just now, first checking the containers, okay, to disperse the cells. Okay, then you centrifuge, okay, the container that contain the fluid, centrifuge 50 ml aliquot, okay, or less than 50 ml of fluid. Then you discard the supernatant, okay, you want the sediment. Okay, the sediment is used for several cytology techniques such as direct smears or cytocentrifuge, thin layer slide preparation, and filtration procedure. And the slides are alcohol fixed, and you proceed the perpendicular stain or pulp stain, okay, the short term for the staining. Or sometimes you can perform MGG staining. And in some cases, I think in special cases where you can't really decide the outcome from the slide, the stain slide, you can pull the cells from the fluid and perform cell blocks. Okay, this is important for the special immunohistochemistry staining. I think this is the video of cytospin. Can I just click it? Okay, yes. But it is in Spanish, students. You just watch the motion. This is how cytospin is performed in the cytology lab. So we put the fluid, this instrument. Okay, that's the fluid, pleural, peritoneal, or pericardial fluid. Then you spin it. Okay, the time there 1500 RPM, 5 minutes. So just now you see they put the fluid into the instrument, the chamber. So after they spin this, the fluid will pull into the one area. And you can directly stain the slide after this. Okay. So just throw this chamber to the safety hazard bin. And there you go. Your slide with the cells on it ready for staining. Okay. Right. I think you don't need to know about it. This is an old method filtration procedure because now we have cell blocks. Okay. In some hospitals, okay, I think because not all hospitals have a cytology laboratory. Okay. But if they have cytology laboratory, they have to perform this cell block technique, cytology cell blocks. Okay. As I mentioned just now, this is for special cases, okay, where you can't really diagnose, or the pathologists in the hospital can't really determine the cells in the fluid, whether it's malignant or not malignant, occurred in the cells. So they have to perform cell blocks. Okay, so the remainder of the sediment, okay, the same sediment just now that from the centrifuge, is wrapped in filter paper. Okay, but first it is fluid, kan? Fluid texture. So how are you going to put it into the filter paper? First, you need to coagulate the sediment, okay, by adding few drops of plasma and several drops of thrombin solution. This is like a medium to make the sediment clothing. Then after that, just for a few minutes, then after that, you can put the clot tissue, the clot specimen to the filter paper. Then the filter paper you put into tissue blocks and embedded in paraffin. Okay. Then after the paraffin blocks, after you made the paraffin block, okay, you can directly cut and stain like you do the normal histology technique. Okay. This is useful for special staining and also for immunohistochemistry staining. Alright, so how are you going to report the outcome or the result from your staining slide? Okay, because if you have a chance to work in the cytology lab, okay, you can you will be the cytology officer, where you will be assigned to do the reporting, and your report will be sent to the pathologist to confirm whether your reporting is right or wrong. Okay, so what are you going to report? After you check your slides under microscope, you can report whether if there is no malignant cells identified, so you report it as negative for malignancy. But you can put a suspicious cells present if you can't decide whether it's negative or positive. Okay, this is usually for cases like cells are poorly preserved, or maybe too few cells. Okay, samples are too few samples for you to support the diagnosis. And if you confirm there is a malignant cells identified, you put it positive for malignant cells. Okay. So for your info, cytology is more sensitive than blind biopsy for serous malignancy. Okay, we start on the what I'm going to look into the cells. Okay, all right. Benign infusions, okay, contain mesothelial cells, histiocytes, and lymphocytes in varying proportions. Okay, the fluid just now that you collected, it contains mesothelial cells, histiocytes, and lymphocytes. Okay, so why it contains lymphocytes? or histiocytes because some bleeding is common during the specimen collection. Okay. And red and white blood cells are common contaminants. Okay. So the mesothelial cells that has been collected, it can be sparse or numerous in benign effusion. Okay, so what are the morphology of the mesothelial cells? Okay. So first, the cells are in uniform. Okay, this is for normal cells. I mentioned normal first. After this, we go to the disease cells. Okay, first uniform, then second oval to round nuclei. Okay, and it has round cell. And the peripheral vacuolation also appeared in the normal mesothelial cells and blebs, which is microvilli. I'll show you the image. Okay, right. So uniform, oval, and round nucleus. Okay. Okay, the cells is round and it has peripheral vacuolation. Okay, you see the vacuolation appearance and microvilli. Okay. And then the cells are usually dispersed as isolated cells or can be sometimes in a small cluster. And then the nucleus, sometimes it can be binucleus and sometimes multi-nucleus. And then cytoplasms, the cytoplasm sometimes dense with clear outer rim. Okay, you see here, this is the clear outer rim, means lacy skirt. The term is lacy skirt. You know macam orang pakai skirt yang ada lace tu. Okay, nampak tak macam rupa lace skirt, lacy skirt. Terminology, oh hello. Right. So you know already about normal cells. How about the reactive mesothelial cells? This one still not cancer cell. This is still benign reactive mesothelial cells. Okay. So with acute or chronic injury, mesothelial cells can undergo hyperplasia and can have significant nuclear atypia. Okay. So it can be due to various causes. Okay. So what are the morphology of reactive mesothelial cells? Okay, because you know already what are the normal cells looks like. So for reactive mesothelial cells, okay, cells are varying in cell size and nuclear sizes. Okay, and increased number of mesothelial cells. Okay, of course the cells, the number may be double or triples. Okay, and it has enlarged central of paracentral nuclei. Okay, and it also has some characteristic like the normal one just now, binucleus and multinucleus still there, but it has prominent nucleoli. Okay. Prominent nucleoli. Okay, here is another example of a picture of reactive mesothelial cells. Okay, this one is from peritoneal fluid. Okay. Another example from pleural fluid. Okay, pleural effusions. Okay, so for reactive mesothelial cell, okay, it has a variable in size, and reactive mesothelial cells tend to present in a more monolayer arrangement. Okay, monolayer. See, monolayer arrangement, and not in the large 3D cluster. Okay, later on you will see if it is malignant, it will form like a clump. Okay. Alright, now we go to malignant. Okay, some tumors have a greater tendency than others to spread to the serosal cavities. Okay, so bear in mind, students. So even though the malignant cases here, it can be from the serosal cavity itself, from pleural, pericardial, or peritoneal, or it can be caused by the tumors from other organs that go to that serosal cavity. Okay, like lung cancer, breast cancer, or other cancers that can travel to the cavity. But from statistics, other cancers from other organs have more prevalence or percentage than the malignant in the serosal cavity itself. Okay. So the most common causes of malignant pleural effusion is from what? It's from lung cancer. Okay, in both men and women, right? And about the peritoneal, just now you know about pleural, but for peritoneal, okay, the most common causes cancer that can cause peritoneal effusion are from the intestinal and pancreatic cancer. Okay, intestinal can be gastric or can be colon cancer, okay, or in men, and ovarian cancer in women. Okay. So if the patient, okay, have been diagnosed with positive pleural or peritoneal effusion, okay, so sad news to them, because the median survival, okay, this patient can only survive, okay, for 6 months, okay, in some cases in less than 6 months, okay. So student, you rasa 6 bulan ni pendek ke tak?
Pendek.
Pendek kan? So kalau you all terdengar kes siapa-siapa lah kan kat luar sana yang dah detect positif pleural or peritoneal effusion, namanya dia dah kena ni lah, bersedia lah kan, sebab hanya ada 6 bulan saja untuk hidup, right? Okay, here in this table it shows you the most common tumors that can cause malignant effusion. Okay, I've already mentioned just now here, but this one I summarize in the table format. Okay, you can see this is in order. For men, lung, woman, breast, but lung also second in woman. Okay, and peritoneal, okay, like lymphoma, GI tract, okay, and ovary for women. Okay. Okay, we first go to the first malignant cases is malignant mesothelioma. Okay, as I mentioned, the malignant effusion in the 3 cavities here can be caused by the mesothelial itself, mesothelial cell itself, or it can be caused by the tumor cells from other organs. Okay, from these organs travel to mesothelial serosal cavity. So first malignant mesothelioma, it accounts for less than 2% of malignant effusion. So if we compare all of this cancer with malignant mesothelioma ni kalah lah, only 2% je case malignant mesothelioma, okay, compared to lung or other cancer ya, bagi banyak percentage yang prevalence dia. Okay. So what are the cytologic features? So one cell population of malignant mesothelial cells, okay, dia selalu duduk dalam one group, one cell population, okay. Alright, another feature is it has large clusters, okay, large cluster here with irregular knobby flower-like borders, okay, irregular borders, okay, or in the terminology they put it as knobby or flower-like borders. And the cytoplasm is dense, okay, with delicate lacy cytoplasm again, okay, and central nucleus and enlarged nucleus with macronucleoli and irregular borders of the nucleus. Okay. This is the image, example image of the malignant mesothelioma, okay, from pleural effusion. Again, this is another example of malignant mesothelioma from pleural effusion. Okay, see a large cluster. Okay, so it's different to the normal cell just now. Okay, it doesn't perform like large cluster in this image. Okay, and more examples of images, okay, of malignant mesothelioma, right? Large clusters. Again, another images. Right. So what are the tips? Okay, here I put some tips for you to identify or detect the malignant cells in effusion. Okay, just now you receive the slide, you collect the specimen, you stain, and you view under microscope. So as a cytology officer, okay, in the future, so how are you going to detect the malignant cells in the pleural, peritoneal, or pericardial effusion? Okay, first you have to look for the second population. Okay, how you going to look for second population? Of course, first you need to know and remember how the normal mesothelial cells look like. If you know already what's the morphology of normal mesothelial cells, then anything other than that, you know that they are different population. Okay. So second population here also means that other cells that are not belong to the serosal cavity, like the lung cancer, the breast cancer, okay, the tumor cell from the other organs travel to serosal cavity. That is the second population. So the malignant cells are not necessarily larger than mesothelial cells. So beware, cancer cells not necessarily larger than the normal cell. Okay, it can be same size. Okay, and of course it has high nucleus to cytoplasmic ratio. And another feature is it has macronucleoli and numerous large cluster of cells. Okay, this one is important. You see a lot of image here, large cluster. Okay, this is another important feature. Okay, and one more, if you perform cell block, okay, this is the cell just now that has been pulled to in filter paper, and you do normal histology section. Okay, so you will see the cells are often situated in lacuna. Okay, this is this space here. This is the lacuna. Okay, so the cell inside here is the malignant cell. Okay, mostly for adenocarcinoma. Okay, example lung adenocarcinoma. Alright. Now we move to, you know already about the malignant cases of malignant mesothelioma. So we want to know about how you want to differentiate if the malignant cells in the serosal cavities from the metastatic tumors and not from the tumor in the mesothelial cell itself. Okay. Okay. First, adenocarcinoma. Okay. Example, lung adenocarcinoma. Okay. So here is the features of the lung adenocarcinoma. Okay. Large spheres or single cells. Increased nuclear to cytoplasmic ratio. You have the cytoplasmic regulations, large or irregular nucleoli, and one more important feature is signet ring cells. Okay, this is for gastric or breast adenocarcinoma. Okay, this is the image of signet ring cell. Okay, this is in the gaster, okay, stomach. Okay. Okay, second metastatic tumor is squamous cell carcinoma. Okay, example here in the cervix. Okay, so the features are large cluster. Okay, large cluster, or sometimes it can be isolated as well, and it has hyperchromatic nuclei, and the cytoplasm is dense and occasionally orangeophilic. Okay, this is a I think squamous cell carcinoma is really easy to be detected because it is orangeophilic. Okay, orange color. Okay, here, orange color. Okay, so if you see the cells performs this orange color, you know already, oh, this is not a mesothelial malignant cell from the mesothelial cell itself. This is second population. Okay, this is a foreign cell travel to the serosal cavity. Okay. The third tumors is from the small cell carcinoma. Okay, the example here is lung small cell carcinoma. Okay, the features are small cells isolated in chains or in clusters, sometimes in clusters, and it has nuclear molding. Okay, I put here the what's this nuclear molding. Okay, and it has scanty cytoplasm. Okay, and the fourth cases are from melanoma. Okay, Usually it is single large cells, okay, and it has large eccentric nuclei, okay. And in the melanoma cells, it show fine brown cytoplasmic pigmentation. Okay, sometimes it show brown cytoplasmic, but sometimes it's hard to see the brown pigmentation. And some cases you see intranuclear pseudo inclusion. Okay, but binucleus is common in melanoma cells, the malignant cells from melanoma cases. Okay, and very prominent nucleoli. Okay, very prominent nucleoli. But sometimes the cytology officer can be, or maybe the pathologist itself, okay, it can be very difficult for them to differentiate whether is this the melanoma, is this the malignant cell from the mesothelial cell itself. So if you find it difficult, okay, you can just straight away do the immunocytochemistry test. Okay, you do this to marker protein S100 and HMB45. Okay. Alright, so here are some suggested immunohistochemistry markers. Okay, in a case where you can't really decide what are the malignant cells. Okay, if you said in the report you said that yes, positive for malignancy, but what cells? You can't decide whether it's for mesothelial, whether it's lung, whether it's breast cancer, or whether what. So you do this immunohistochemistry markers. Okay, put here the list. Okay. So the result, okay, let's say yes, K7 should be negative for gastric adenocarcinoma, okay, and the rest here should be positive. Okay, this is negative. Okay, again here. Alright, I think we come to the end of our lecture. Students so far okay ke? Faham ke? I think it's more like morphology, right? You need to differentiate. But if you know already what are the normal mesothelial cells, then I think inshallah you know already, you will grab it. Then you know, okay, the differentiation between malignant and normal cells. Sudah okay ke?
Okay.
Okay, doktor.
Okay. So how you're going to report this? If you, let's say you receive this case, okay, you do the staining semua. Okay, 60-year-old woman presented with ascites of unknown origin. Okay, so how are you going to report this? Positive, suspicious cells, or negative? Student? 3 answer only. Positive, suspicious, or negative?
Suspicious.
Suspicious.
Okay, another answer. Tengok ni, you ingat ni apa ni? Negatif ke positif? Ha. Student, there are only 3 ways for you to do reporting. Positive for malignancy, suspicious cells, or negative for malignancy. Okay, which one?
Positive.
Positive? Is this malignant cell? Do you think this is positive or negative?
Negative.
Yes, this is negative. Okay. This is just reactive mesothelial cell. Okay. That's why it can be hard to differentiate reactive to just benign, and malignant. This one you report as negative. Okay. Okay, how about this?
Positive.
Positive.
Yes, big positive. This is easy, positive. Okay, I think that's all. Okay, let's play Kahoot to see whether you really understand this topic. Student, you can Open maybe your phone or laptop. Enter the pin. Okay, the first winner I will give Grab cash. Okay, pemenang tempat pertama saya akan bagi Grab cash reward. Okay, only 39. We wait 2 more minutes. Saida ada ke Saida?
Ada doktor.
So far macam mana attendance?
Nanti saya download dekat participant list je.
Okay.
Okay.
Nanti Saida mesej saya
Okay.
Okay, shall we start now student?
Yes.
Oh, you nak tunggu kawan you lagi ke? Kita start now lah Saya nampak nak masuk. Okay, I will start now. Okay. True or false je semua. Is it true or false? Yes, it's true. Cytology is more sensitive than tissue biopsy for detecting serosal malignancy. Okay, so 50 of you answer correctly. Okay, well done NSF. Macam nama pasar raya. Okay, second true or false question. Mak tersilap je. False positive False positive in cytology diagnosis occur in less than 1%. Sikit je kesalahan. Betul ke? Dalam cytology diagnosis. Okay. Nampak tak majority answer salah tapi 22 of you answer correctly. Okay. It's true. In cytology diagnosis, it's sensitive and specific. So, it occurs only less than 1% false positive. Mostly, 99% cases correctly diagnosed. Okay. Wah, siapa ni? Tak tahu nama dia. Leave je. Alright. Okay, next. True or false? Most malignant cells will have the window appearance. Is it for malignant cell or normal cell? Okay, the answer is false. Okay. Most malignant cells will have window appearance. No, the answer is wrong. It's for normal cells. Okay. Most normal cells will have window appearance. KS, well done. A second population of cells cannot be seen in malignant effusion from melanoma cases. Okay. True or false? True sama 29, 28 equal. So answer is true. Okay, usually in melanoma cases, malignant effusion daripada melanoma selalu pathologist or cytology officer really hard to find the malignant second population of cells. Okay, so usually in melanoma cases they will perform immunohistochemistry. Okay, well done. Most patients with a malignant effusion have no history of primary neoplasm. Is it true or wrong? Okay, the answer is false. Okay, of course, the patient with malignant effusion need a history of primary neoplasm because in malignant effusion, just now I said you only live 6 months, so dia dah metastasize lah. So you need a history of primary neoplasm. Okay, hungry. Lapar ya? Okay, sikit lagi. Okay, lung cancer is the most common occult in women and men who present with a malignant pleural effusion. Betul ke? Ni saya ada mention tadi. Okay, skip. Alright, 45 you answer correctly. Okay, yes. Okay, lung cancer is the number 1 causes. Okay. Okay, well done, hungry. Okay, 2 more questions. Malignant cells are not necessarily larger than mesothelial cells. Okay. So I also mentioned just now. Can be same size or not. Okay. Yes, true, right? So yes, malignant cells are not necessarily larger than mesothelial cells. Oh, hungry again. Okay, last question. Okay, is it true? Cytology direct smears more sensitive than cell blocks. Okay, 60 answer will skip. 34 of you are wrong. Okay, the answer is false. Okay, cytology direct smear is not. If we compare the sensitivity, cell block is more sensitive than direct smears. Okay. Okay, let's see who's the winner. Oh, hungry jatuh tadi mesti salah Okay, nombor 2. Okay, leave. 1. Okay, me. Okay, me nanti message saya nanti saya akan forward Grab cash to you. Siapa me ni? Boleh reveal. Siapa me? Hello?
Hello, doktor.